Assalamualaikum and hi everyone. Welcome to OPT501 Ocular Pharmacology. I'm Mr. Faiz will guide you for the first lesson entitled General Principles of Ocular Pharmacology. At the end of this course, or more particularly in this topic, you should be able to grab the knowledge base in pharmacology, especially on administration and bioavailability of ocular therapeutic agents and diagnostic ophthalmic agents. Besides that, you should have an essential knowledge of the factors affecting ocular drug bioavailability in the treatment of ocular disease. These are important that will benefit for your future optometry practice. Let's recap back. What do you have learned in the last semester OPT601 General Pharmacology? Pharmacology is a study that consists of pharmacokinetic and pharmacodynamic, ADME, or absorption, distribution, metabolism, and excretions are the key factors for pharmacokinetics. To achieve the optimum therapeutic effects, drugs or any diagnostic agent should have good bioavailability. However, in this classical pharmacokinetic model of systemically administered drugs do not fully apply to many ophthalmic and ocular drugs. Although similar principles of absorption, distribution, metabolism, and excretion determine the drug disposition in the eye, these alternative routes of drug administration introduce other variables in compartmental analysis. So, in this topic, we will cover the variables that affect the drug bioavailability in the treatment of ocular diseases. In these sections, we will focus on available ocular therapeutic agents and diagnostic ophthalmic agents in the market and the possible absorption pathway. Before we begin, let's see our eyeball first. The structure of the eye itself are divided into two parts, the anterior segment and posterior segment. The anterior segment include the cornea, limbus, anterior and posterior chambers, iris, lens, and ciliary body. Meanwhile, the posterior segments consist of the sclera, choroid, retina, vitreous, and optic nerve. The anterior surface of the eye is covered by the conjunctiva. The retina is the sensitive layer which creates nerve impulses that are transmitted through the optic nerve to the brain. The macula is a specialized area of the retina that is responsible for the central high-resolution color vision. The retina and macula can suffer from different disabling illnesses such as age-related macular degeneration, cystoid macular edema, diabetic retinopathy, and ocular vascular occlusion, which are the leading causes of non-reversible vision impairment. This retinal disorder could be pharmacologically addressed. However, the efficient and safe delivery of drugs to the retinal tissue is not a completely solved subject. Most ophthalmic medications are formulated to be applied topically or may be injected by subconjunctival, subcutaneous, and retrobulbar routes. Gels, ointments, solid inserts of contact lens, and collagen shield are the available preparations that prolong the time a drug remains on the surface of the eye. Prolonging the time in the cool state facilitates drug absorption. However, this topical drug only effective for the treatment of the ocular surface in the corneal and conjunctival tissue and the treatment in the anterior segment disorders. These conventional topical drugs are hardly to penetrate into the posterior ocular segment, which are believed only ocular bioavailability are less than 5%. Therefore, intravitreal injection are the most frequent pathway to deliver drugs for the treatment of posterior ocular globe disorders. Today, the use of intravitreal injection are now being used in the drugs such as corticosteroid, antimetabolites, antibiotic, and anti-VEGF therapies. However, this intravitreal procedure is associated with severe complications such as endophthalmitis and retinal detachment. Besides that, it might be a burden for physicians due requires highly specialized training and high-spec infrastructures, which resulting in an expensive therapy option. Intracameral delivery involves injection into anterior chamber of eye to deliver drugs such as antibiotics following the cataract surgery. Besides that, bevacizumab also can be used in this route to reduce the corneal and iris neovascularization. However, drug delivery to posterior segment with intracameral route may not be significant. Disadvantages of this route include the requirement of repeated injections due to rapid turnover of aqueous humor, which increases the risk of infections. Besides that, this route can obstruct trabecular outflow and raise the intraocular pressure. For intravitreal injection, small molecules distribute rapidly, whereas large molecules display limited distribution. Distribution in the vitreous areas are affected by the molecular weight, surface charge of molecules, pathologies affecting vitreous, and age-related vitreous liquefaction. Periocular routes include subconjunctival, subtenon, retrobulbar, and peribulbar administration. These routes are used to deliver drug to posterior segment of the eye. Posterior subtenon route is demonstrated to deliver highest concentration in vitreous with minimum systemic level compared to other periocular routes. Drug administered via periocular routes reach posterior segment via transscleral pathway, circulation in choroid, or through arterial pathway. Size of particle is an important determination of kinetic following periocular administration. Particles more than 200 nanometer size are retained at site of injection for over 2 months. Let's see the possible absorption pathway following topical application to the eyes. If you can see here, the solid black arrows represent the corneal route. The dashed blue arrows represent the conjunctival or scleral route. The black dashed line represents the nasolacrimal absorption pathway. Topically administered drugs may undergo systemic distribution primarily by transcorneal, transconjunctival, and nasolacrimal absorption pathway. Transcorneal is the major pathway for drug absorption. The aqueous humor accumulates the drugs, which then is distributed to intraocular structures and potentially to the systemic circulation. Transcorneal drug penetration is a differential solubility process due to the cornea's trilamellar fat-water-fat composition. The epithelium and endothelium of the cornea represent barriers for hydrophilic substances, while the stroma is a barrier for hydrophobic compounds. Hence, a drug with both hydrophilic and lipophilic properties, also known as amphiphilic drugs, is best suited for transcorneal absorption. Nasolacrimal drainage contributes to systemic absorption of topically administered ophthalmic medication. Absorption from the nasal mucosa avoids the so-called first-pass metabolism by the liver. However, it is non-productive due to penetrated drug is absorbed by the general circulation. The drug concentration gradient between the tear film and the cornea and conjunctival epithelium provide the driving force for passive diffusion across these tissues. Other factors that affect drug diffusion capacity are the size of the molecule, chemical structure, and steric configuration that we will discuss later in this part. Here is the second part of the lectures. In this part, you will be able to identify barriers for ocular drugs such as anatomical, physiological barriers, and metabolic barriers. Besides that, the ophthalmic drugs and diagnostic agents also one of the factors affected the bioavailability of the drugs. Ocular drug delivery faces huge challenges compared to other drug delivery to the other organs. It is because eyes are composed by very sophisticated ocular barriers. Many of these barriers are inherent and unique to ocular anatomy and physiology, making it a challenging task for drug delivery innovations. Corneal and conjunctival epithelium, blood aqueous barriers, or also known as BAB, and blood retinal barriers, or also known as BRBs, are the fundamental structures that restrict the passage of molecules and fluids to the retina and impede the drug penetration. Moreover, various elimination mechanisms such as tear turnover, nasolacrimal drainage, protein binding, and enzymatic degradation limit the ocular bioavailability of the drugs. Let's move on to the first barriers, which is anatomical barriers. The mode of administration of a drug is an important factor in determining the ocular tissue distribution. The eye is protected by a series of barriers such as blood-retinal barriers, blood-aqueous barriers, and blood-vitreous barriers. As a consequence, the eye exhibits some unusual pharmacodynamic and pharmacokinetic properties. That is why the eye presents some unique opportunities as well as challenges for drug delivery. Cornea is about 500 micrometer thick. Is considered to be a primary barrier to absorption of topically administered drugs. It displays relative impermeability to both hydrophilic and lipophilic drugs due to epithelium layer that lipophilic and stroma layer that hydrophilic in nature. Thus, hydrophilic drugs are restricted via transcellular pathway, while small molecules via paracellular pathway respectively. Macromolecule diffusion through paracellular pathway is completely restricted by tight junctions. Normal tear film is about 4 to 9 micrometer thick and has a volume of 7 to 10 microliter. This can increase to 30 microliter in the absence of blinking. Upon topical administration, drug is immediately mixed with tear fluid. However, it has low retention in precorneal regions. Is about 1 to 2 minutes due to constant flow of tears, which is 1.2 to 1.5 microliter per minute, and drainage. Drainage rate is usually much faster than rate of absorption. Besides that, poorly water-soluble drugs are easily to bind to mucin, which demonstrate poor drug permeation. Vitreous humors consist of solutes, ions, collagen, and hyaluronic acid. It demonstrates better permeability to anionic molecules due to negatively charged hyaluronan. Drug administered via intravitreal route can be eliminated via anterior pathway, which involve passage of drug molecules into aqueous humor followed by clearance through aqueous turnover and uveal circulation. Posterior pathway requires drugs to permeate through blood-retinal barrier and uptake by transporter system in RPE. Drugs eliminated via both routes, such as small lipophilic drugs, demonstrate a shorter intravitreal half-life as compared to those eliminated only via anterior pathway, such as large hydrophilic drugs. The blood aqueous barriers consist of endothelium of iris or ciliary blood vessel and non-pigmented ciliary epithelium. It exhibits presence of tight junctional compresses restricting entry of solute into intraocular environment such as aqueous humor. The barrier also restricts entry of hydrophilic drug from plasma into aqueous humor. However, in the presence of inflammation in these areas will increases the drug permeation. The blood-retinal barrier restricts entry of plasma components, water, and toxic substances into retina. It consists of an outer blood-retinal barrier that formed by the retinal pigment epithelium, or also known as RPE. It also consists of an inner blood-retinal barrier that formed by tight junction endothelium of retinal blood vessel. Outer blood-retinal barrier, such as RPE, demonstrates significant resistance to hydrophilic molecules and limited permeability to macromolecules. Let's move on to the second part of the barrier, which is physiological barriers. Tear film demonstrates a limited buffering capacity and lacrimation that can be stimulated by even mildly irritant solutions. Normal pH of tear fluid is approximately 7.4. To avoid the reflex lacrimation, the drug formulation should have a pH between 7.0 to 7.7. Blinking is a normal reflex that protects the eye from dryness, bright light, and fingers or other objects that come toward it. Blinking also regulates tear, which nourish and cleans the surface of the eye. The blinking rate in newborns is only 2 times per minute. This increases to 14 to 70 times per minute in adolescents and remains at this rate throughout the rest of the lifetime. Conventional droppers used for administration of ophthalmic solution deliver approximately 50 to 75 microliter per drop, which largely exceeds retention capacity of lacrimal sacs, which is only about 7 microliter. Thus, it will cause a considerable amount of drug loss from the spillage and drainage. The osmotic pressure of the choroid is about 12 to 14 mmHg, and the vitreous humor has an osmotic pressure of approximately 0 to 1 mmHg. The differences in osmotic pressure between the choroid and the vitreous generates a fluid flow toward the choroid. The hydrostatic pressure difference between the suprarocoid and the episcleral tissue also contributes to the outward bulk fluid flow. There is a hydrostatic pressure difference of about 12 mmHg between the suprarocoid and the episcleral tissue, which works as a driving force for the outward bulk fluid flow. Melanin, normally present in uvea and RPE, which is retinal pigment epithelium, have high affinity toward basic and lipophilic drugs. Melanin binding significantly reduces the drug available for therapeutic action and warrants use of a larger dose. Melanin binding in iris ciliary body affects the drug response in anterior segment, while that in choroid branch membrane and RPE affects high resistance to penetration of drug in retina and vitreous due to the presence of melanin. Drug efflux pumps such as P-glycoprotein and multi-drug resistant associated proteins have been reported in RPE with an efflux effect directed toward the choroid. The third barrier is the metabolic barriers. Phase 1 and 2 metabolizing enzymes are present in the eye and commonly belong to CYP450 family. In addition, lysosomal enzymes are also abundant. These enzymes are detected in high concentration in iris ciliary body, choroid, and RPA, and to a lesser extent in cornea, lens, aqueous humor, and vitreous humor. Metabolic activity is also present in blood ocular barrier, which lower intraocular drug concentration. The rate and extent of absorption are determined by the contact time, which the time the drug remains in the cul-de-sac and precorneal tear film, that will lead to diffusion across the cornea and conjunctiva. Besides that, the bioavailability of the drugs also impaired by the drug binding to tear proteins, drug metabolism by tear and tissue proteins, and also drug elimination by nasolacriminal drainage. Viscosity helps to retain drug for a longer time in the precorneal region, increasing the contact time. Rate of solution drainage is shown to decrease with an increase in the viscosity. Acceptable viscosity level is considered as 20 to 30 centipoises. Viscosity below a certain level does not significantly improve intraocular drug bioavailability, while a further increase in viscosity interferes with visual field. And also, the viscous solutions are difficult to filter and sterilize. Optimum lipophilicity of drug for corneal absorption is considered as octanoe-water partition coefficient between 10 to 100. An increase in lipophilicity restricts the drug diffusion since the drugs bind to lipid membranes of cornea. An increase in drug concentration in ophthalmic solution can improve corneal penetration in accordance with Fick's law of diffusion. Thus, it will enhance the clinical efficacy of the drug. Smaller particle size present a greater surface area and increase surface-specific dissolution rate and permeation across the cornea. Drugs with molecular weight less than 500 Dalton display better corneal penetration primarily through passive diffusion. Particles with sharp angle are more irritant and induce the reflex lacrimination. Transcorneal permeability of hydrophobic or biphasic drug is primarily governed by lipid solubility, while the hydrophilic substance is primarily governed by the molecular weight. Mucin layer on anterior surface of cornea possesses a negative charge and normally repels the anionic drugs. Pores in corneal epithelium present a negative charge and hence positively charged molecules demonstrate better penetration through cornea. Positively charged colloid solutions are demonstrated to be superior in ocular drug delivery when compared to an anionic or neutral counterpart in many studies. Positively charged molecules get bound to negatively charged proteoglycan matrix of sclera and exhibit poor penetration via transscleral route. Choroid root membrane is also less permeable to cationic molecules. Hyaluronan A negatively charged glycosaminoglycan in vitreous can form immobile complex with positively charged molecule. This complex aggregate and reduce the drug delivery to retina. Here is the basic summary of what you have learned today. Ophthalmic drug delivery remains a significant challenge owing to presence of a number of physiological and anatomical barriers. Knowledge of properties of different barriers can help the clinicians select an appropriate drug and/or formulation for ocular pathology. That's all for today. Kindly answer one question attached here individually as a proof of your attendance. These questions also can help you to identify the key areas that you should be able to grasp from this topic. If you have any questions or inquiries, please do not hesitate to ask in the comment section below. Bye. See you next time.